Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Maitri Juna. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota.
Hypoglossal nerve stimulation. It is so widely advertised to the public as an apparent solution to obstructive sleep apnea, avoiding the need to use CPAP. How realistic is this? To discuss this topic today, my guests are Dr. Michael Olson, an otolaryngologist and head and neck surgeon at Mayo Clinic, who specializes in surgeries for obstructive sleep apnea, and Dr. Maitri Juna, a neurologist and board-certified sleep specialist at Mayo Clinic with expertise in managing patients who have hypoglossal nerve stimulators. So welcome to you both. Mike, let's start with many patients watch these blizzards of advertisements for hypoglossal nerve stimulators and ask if it would be a good alternative to CPAP. So, practicalities. Will the procedure be paid for if a patient has not had a trial of CPAP, or does one need to fail CPAP first? And if so, how do the insurers define failing CPAP? Is it different between different payers and specifically between Medicare and private payers?
Mike, thanks for having me on the podcast today. I've been very excited to come and talk about this topic. Your question is an excellent one. It's valid. It's a bit challenging to describe exactly what every insurer will cover in regards to hypoglossal nerve stimulation therapy. But in general, the FDA approval criteria for this device includes individuals who are intolerant to CPAP. Now, intolerance is a broad definition and a broad word. We generally like patients have tried CPAP and failed CPAP. Failure can be described in a number of ways. For some individuals, failure is, I just can't take this anymore. I can wear it 8 hours a night, but perhaps I'm just very dissatisfied with either improvements in daytime function or challenges related to a variety of things that patients commonly complain about, recurrent mask leak, et cetera, et cetera. And so there are certainly patients in that space who can tolerate the mask, but are looking for alternatives. And then there are patients who do not tolerate the device at all. Insurance generally likes, and I as a sleep surgeon like a patient to have at least trialed a CPAP or some other non-surgical method before considering surgical alternatives such as the airway stimulator. And so I'm pretty firm with my patients in regards to that because, as we all know, CPAP and oral appliance can't hurt you from a surgical perspective. They're safe, they're predictable, they're reliable. And so my feeling with patients who've never tried CPAP before is that they really should try. And so that's generally how I approach this situation.
And Medicare is exactly the same.
Yeah, Medicare has very similar verbiage in regards to what the FDA approval criteria is, which is CPAP intolerance. And so interpretation of that, I think, is left to both the patient and the surgeon. And your surgeon should certainly try to exhaust every option that can be exhausted to see if we can get you on CPAP and tolerate CPAP before we consider alternative therapies.
And what are the current limitations on AHI and BMI to qualify for the procedure, Maitri?
So, the current FDA-approved indications, at least in adults, include an AHI range of 15 to 100, of which at most 25% can include central or mixed apneas. And as far as the BMI, the current FDA-approved indication, as for the upper limit, is 40.
Okay, well, that's certainly is a bit of a change because we sort of learned that above 35 didn't qualify, so that gives a wider range of patients the opportunity to benefit. And what about children? Is it approved for children?
Great question. So, yes, it is FDA approved for children ranging from 13 to 18 with Down syndrome. And in these individuals, the AHI range is 10 to 50. And the BMI cutoff is that it has to be less than the 98th percentile. A drug-induced sleep endoscopy is also part of the equation when establishing appropriate indications for Inspire therapy in that patient group.
Well, that's so good to hear because so many Down syndrome patients, especially more heavily handicapped ones, have terrible trouble tolerating CPAP. So it's wonderful there's now another option for them with sleep apnea being so common in this group. Now, does the patient, things have changed a little, but does the patient still need to undergo an examination under anesthesia to determine the type of closure of the oropharynx in order to qualify, Mike?
Yeah, yes, the answer is there are specific criteria that will allow the patient to consider undergoing surgery and placement of an upper airway stimulator. Dr. Druna pointed out some of the medical qualifications, such as AHI limits, percentage of central and mixed sleep apnea. For one of the important steps is what's called, as you point out, a drug-induced sleep endoscopy. And what that is a procedure where we bring the patient to the operating room and an IV is placed and sedating medications are provided to the patient, which then will allow us to place a scope in the nose, taking that scope to a variety of places within the upper airway to assess how that upper airway moves. We've known through research and previous study that there are some types of airway collapse and movements of the airway that do not respond to airway stimulation therapy. So a part of that workup or evaluation has to include this. And I generally tell patients that approximately 1 in 5 patients will have what we call complete concentric collapse, which is at the top part of the airway, the throat is collapsing much like a circle collapses or in a circular way, instead of what we would describe as sort of the front and back collapse, which is more typical. Those patients that have a circular collapse do not do well with this from a reduction in their sleep apnea. And so if we see that, we have to think about other alternatives and other types of surgeries.
So it would be fair to say statistically about 80% of patients who reach this point will come out of that brief procedure saying, yes, you are a candidate.
Exactly right. Yes,
Great.
exactly right. And luckily, the other thing that I would point out with the drug-induced sleep endoscopy is that although we're looking for this specific problem, the concentric collapse, with the endoscopy for the airway stimulator, we also can see some other signs and other types of patterns of collapse that might help us determine whether the patient may have a more robust response or less robust response. Do we need to consider additional surgery? So the drug-induced sleep endoscopy can be helpful in a number of different ways.
Good. Well, let's now go on to the procedure itself. What exactly is done? How long does it take? Can the patient go home the same day? What do you tell patients about post-operative immediate symptoms? And how long do any immediate consequences last?
Great. So in the time before airway stimulation therapy, we had 2 surgeries, and both had a fairly robust recovery. Throat surgery and jaw surgery came with an extended recovery and extended, amounts of discomfort, etc. Airway stimulation therapy has found a fairly nice niche in that the surgery itself, although surgery, is a much better tolerated from the perspective of recovery. So the procedure itself is done in the operating room under general anesthesia. There are 2 incisions that are made currently. One incision is under the right jawline, and that incision can be quite small. And then the second incision is on the right chest. And the right chest incision has to be slightly larger because that's where the device will be implanted. It takes about 2 hours to perform the procedure. The patient can go home the same day. And the recovery, I generally tell the patients, is trying to lay low for approximately a week, trying to reduce the movement of the right arm as to prevent any complications from the movements of the arm. I generally tell people, we don't want you going out and shoveling the driveway or rearranging the kitchen for about a week, but after that, you can return to normal activities. Immediate complications that we fear but are very rare. The most important one is infection. Infection with a device is unfortunately a bit of a challenge. because it's very rare that we can rescue that situation with medications such as antibiotics alone. If infection happens, it often requires removal of the implant. There are other small risks that are very, very infrequent and generally very well tolerated surgery. Recovery is not particularly painful, certainly not pain-free, but again, well tolerated, and the recovery is fairly short.
Oh, that's certainly reassuring. So the procedure involves placing the pacemaker, if you like, device, and then tunneling subcutaneously the wires to the hypoglossal nerve, and then or a cuff around the hypoglossal nerve.
Yeah, exactly right. So the IPG, as we call it, which is the implant pulse generator, is what most patients would look at and say, oh yeah, that looks like a pacemaker. Now there are two wires that come out of that device. One wire will go down to the wall of the chest or the chest wall, and that is our respiratory sensor. And that sensor essentially looks at the patient's breathing and says, okay, patient's taking a breath, patient's taking another breath. And with every breath, another wire, which is again, as you point out, sort of fished under the skin to the nerve in the neck, then stimulates the tongue, and the tongue will then be protruded and stiffened to allow for a greater opening in the back of the throat, and then hence reduction in the sleep apnea.
Okay. So a lot of patients think, good, I've got over the surgery, let's turn it on and I'll be cured. But of course, it isn't like that at all. It's a long process following surgery. Maitri, tell us about what happens after they've recovered, after that first week or two. What do they have to go through and how is it done?
Excellent question, Mike. So, in general, patients return to the sleep medicine office for a visit at least 1 month after surgery. So, sometimes it's a little bit longer, but not sooner than that. And when they come in for that office visit, we actually turn on the device or activate it.
For the
And
first time. That's the
for the
first time
first
the
time.
device is turned
That
on.
is correct. That is correct. So that initial 1 month period when they are at home, they are really healing, recovering, and etc. So when they come into the office to have the device turned on or activated, we will then set a variety of stimulation amplitudes or provide the patient with a range of amplitudes that they can work with over the next 3 months. And those range of amplitudes include 11 levels. So they begin at level 1, which is the lowest stimulation amplitude that we have programmed, and then increase by a single level once every 7 nights, sometimes longer, but not shorter, as tolerated. So we really want them to get as high as they can in that 3 month window and be able to tolerate it, meaning that they can comfortably sleep with the therapy on all throughout the night. And so for some patients, that may be as low as level 1. And for some, it may be level 11. But nevertheless, they have 11 steps, if you will, that they can work with over that 3 months. And that's really to allow the tongue to acclimate to the stimulation and for those muscles to get stronger, if you will, over time. At the end of that 3 month window, then the patients return to us. We see them in the office and they then undergo what's known as a fine tuning sleep study, where we really work to dial in the exact stimulation settings that are necessary to treat both the snoring and the sleep apnea in that particular individual. The following morning after the sleep study, we then reprogram their device potentially to a different or smaller range of amplitudes that we think will be most effective for them. And thereafter, the follow ups really range, I would say, for that next initial follow up, somewhere in the range of 3 to 6 months. And it really sort of depends on how they're doing in terms of what the window is. But yes, it's definitely a process after implantation. And I would say at least 4 months, sometimes longer.
Now, wouldn't it be, just as I'm thinking about it, better to do that study at first to see what the optimal level is, and then tell the patient where, the one that worked was 7 to was at least 7, and you start low and see if you can tolerate it, but there's a goal to strive for, rather than they say, I got as far as 5, and then 3 months later you do the study and says, sorry, it didn't work until you were at 7. Wouldn't it be better to do it first?
I think that's a very good question and a logical question. My understanding, however, is that at least in some patients, it's certainly possible that the nerve may take a little bit longer to heal. And so, whatever amplitude you might need to achieve adequate tongue protrusion or airway opening in the beginning may not necessarily be what you will need at 3 months or even
Yeah.
4 months. Plus, they might not tolerate it. And so, if they initially don't tolerate it, they may then be dissuaded from using the therapy or gradually working their ways up in terms of tolerability. Um, so those are my initial thoughts, unless Dr. Olson, do you have other thoughts about that?
Yeah, it's a great question. I think Dr. June is exactly right. If we brought them to the sleep clinic and sort of found out that level 7 was what we needed to get their sleep apnea under better control, I think it'd be pretty rare at that 1 month postoperative visit for them to actually be able to sleep or for us to understand that level 7. So I think it really boils down to the healing process over that time period that allows the patient to slowly work up to their amplitude that's required, or hopefully that we find that's required to reduce their sleep apnea. Low and slow is generally the mindset of this process, slowly titrating day by day, which would ultimately give the patient the highest likelihood of tolerance.
That makes complete sense. Thanks for
Mhm.
clarifying that. One more question about this. When they turn it on, how many of the patients, in the first week or so say, this is terrible. I never realized how that I'm going to feel my tongue jerking forward, or it doesn't that happen?
I would say that is a minority of the time, or minority of the patients that complain about that at approximately 1 month. The reason being, the settings that we find in the office are just enough to move the tongue minimally or a few millimeters past the lower incisors is sort of a rough guide that we use. We do also turn the device on for a few minutes in the office visit itself to give them a chance to sort of feel what it's going to be like at home. And the last comment that maybe I would make is when we program the device, there is actually what is known as a start delay of usually 30 minutes, but we can make it longer. That allows the patient time to fall asleep before the device turns on. And similarly, we program what is known as a pause time or a pause duration, so that if the patient wakes up in the middle of the night for any reason to go to the bathroom or get a drink of water, they can pause the device and it will auto start after whatever set time window we have set, which is typically 15 minutes, allowing them enough time to fall back to sleep and hopefully then not be disturbed by the stimulation.
It's rather like a ramp on a CPAP.
Exactly.
Okay, well, that's a very clear description of what happens. So let's backtrack a little. The patient says, I can't tolerate CPAP. I'm interested in this device. Um, I'm going to ask both of you this. My three first, when you see that patient in the clinic and you're thinking of referring the patient on for surgery, the patient says, well, yes, I'm interested in the surgery, but what is the probability of success? How do you explain that to the patient?
I usually take that conversation in a very general sense and explain to patients that, surgical outcomes can be difficult to predict based upon, at the individual level. And I also really explain that sleep surgery options are there for us to explore if and when first line treatment options either cannot be utilized or have been tried and have not been tolerated. But as far as specific success rates, I really leave those discussions to the sleep surgical team because that varies depending upon their assessment of the individual's airway anatomy.
Fine. So, Mike, the patients come to you. It looks like they're a good candidate. You're all ready to go, and the patient says, Dr. Olson, just before I make my final decision, what's the probability this is going to work?
Yeah.
Give me some numbers. How are you going to? What do you tell the patient when you've got one of these patients, say, an engineer or someone who's used to
Yeah.
thinking in terms of quantitation? What are you going to tell them?
Yeah, these are a great question, Mike. So, the first thing I start out by talking with all my patients about is, there's a reason that CPAP is generally provided to patients. And we want to set up what CPAP does from an efficacy perspective before we start comparing what surgery can offer. So I generally say, CPAP is safe, predictable, reliable, and very effective. 95% of patients have their sleep apnea eliminated if they can tolerate it and wear it. For this specific surgery, we have studies, and in fact, the Inspire Medical Company, who has, manufactured this device, has undergone what we call post FDA monitoring of a large number of patients. So luckily for this particular surgery, we have large studies that give us an idea about how we define success. And the definition of success can be varied. So I'm going to talk about the numbers that I describe in regards to success in reference to reduction in the sleep apnea. So CPAP will cure individuals about 95% of the time or higher if they can use the device. Where the Inspire device, after looking at thousands of patients who have undergone this surgery, and after a year of therapy and reevaluating their sleep apnea at 1 year after therapy, approximately 30% of those patients will be down to that cured level of sleep apnea. And so that's not as frequent and not even really close to what CPAP can provide. So we need to realign our thinking about what success is for sleep surgery. We need to say, well, we're not going to as frequently cure people of their sleep apnea with the device, but what do we need to do to make their sleep apnea safe or potentially not as risky or harmful? And we know that moderate or severe sleep apnea has higher levels of risk, but mild sleep apnea does not come with as many or actually any real long-term morbidity or risk associated with it, such as heart attacks or strokes. So it's more common that we take a patient with moderate or severe sleep apnea and we move them down into a mild level. We don't cure their sleep apnea, but we move them into a safer level. And the success rate of that, or the percentage of that, is around 68 to 70% of patients. So in an engineer's presenting and they want the data, I'll say, about a 30% chance of cure while using the Inspire and the hypoglossal nerve stimulator, and about a 68 to 70% chance of making your sleep apnea safe. That's a very broad stroked overview. But as Dr. Juna points out, there are some findings that may say to me, I don't think that's going to be as good. And I would counsel the patient that, although that's the general population's success rate, I think you may not have as great of a luck in that space, or I actually think you'll be better. And that's really where the individualization of evaluation and airway analysis really comes into play.
Thank you. I don't want to get into the weeds, but your 68 to 70% includes the 30% cure. It's not in addition to the 30% cure.
No, exactly. Good point, Mike. Yep.
Right. So in other words, they may say, well, so there's about a 30% chance that this is not going to help at all, would be a reasonable ballpark figure. That's very realistic and very helpful. Thank you.
Yeah.
So the patient goes ahead, everything goes well, programmed, sent out. What are the long-term potential complications, if any? How often does the device have to be removed and why?
Yeah, so every 10 years, and that's a general number. It can be sooner or later based on the depletion of the battery. The IPG, or the part in the right chest, will have to be exchanged because that's a battery-driven device. It's not a rechargeable device. So there'll have to be a removal, again, every about 10 years or so. The longer-term complications, this is an interesting question. For the other two types of sleep surgery that we have, the longer reliability of those surgeries or relapse of sleep apnea is definitely a known issue, meaning that after 10 or 15 or 20 years, if you've had throat or jaw surgery, it's important to retest the sleep apnea relatively frequently in case a patient has new symptoms. The long-term reliability of this airway stimulation therapy is kind of currently unknown. The small early studies looking at approximately 10 years of therapy, we haven't seen a lot of degradation or loss of effect of the actual stimulation, which is good news. Surgical long risk complications are very minimal. There's always a chance that somebody has an implanted piece of equipment in their body. They could spontaneously become infected, but there's really no other long-term complications that we know of. And that particular circumstance that I described is extremely rare.
Great. So both of you have had now considerable experience working with these patients. Uh, Are, are patients generally satisfied? Can you summarize in a sentence or two, each of you, what you think about it? Is this what conclusions from experience now can you leave with our listeners? Maitri, I'll ask you that first.
Sure. So, in general, I would say that most patients with hypoglossal nerve stimulator therapy are satisfied. That being said, and I think others in the group as well, would generally quote patients about a 20 to 25% chance of either of intolerability to the level of stimulation that we need to be able to treat their sleep apnea appropriately. Now, when that occurs, we do have a variety of advanced programming settings that we can find or establish or try to utilize to make therapy more comfortable for the patient without sacrificing efficacy. That being said, I think, like all therapies, there are still going to be a certain number of patients that either don't tolerate it or in whom it's not going to be effective, as Dr. Olson just shared with us in terms of success rates with the surgery.
Thank you, Mike.
Yeah, and Dr. Junas said it really well. I think the most important factor when I'm evaluating a patient for surgical options is what I would describe as realistic expectation setting. There is no perfect therapy for everyone. And in the setting of airway stimulation therapy, there are certainly some nice features of it, the relatively low cost from a surgical perspective in recovery, and the general, I would say, mostly favorable patient experiences. But that doesn't work for everybody. And I wish we had the ability to predict with great accuracy who is going to hit it out of the park and have a home run with this device and who is going to struggle. And so going into these surgeries with their eyes wide open is a very important thing. In summary, however, I would just say before this therapy was offered, I think we had a much more limited ability to help patients who are intolerant to traditional therapies. So one nice thing about this is a relatively low morbidity or risk procedure that has potential to bring people treatment. And I think that's been a really nice opportunity for patients and sleep medicine and sleep surgeons to be able to offer this therapy for individuals.
Well, thank you both for sharing your expertise. I think you have presented such a very realistic approach to everybody, and I think this will be very helpful to sleep clinicians who are deciding whether or not to suggest it to patients and to refer them. So I very much appreciate you jointly sharing it today. Thank you.
Thanks for having us on, Mike.
Thank you.
We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.